we have an hour, and we are going to, within this hour, do a fairly broad atmospheric view of how can we basically expand our practice, build our practice activities so that we are attuned to some of the alcohol and drug use issues that we often will see in our client population. So who am I? Just real quick. I'm a psychologist. I have about 30 plus years in working in the field for the mental health field with dual diagnosis clients through a variety of community-based programs as well as culturally specific programs. And so part of what I'm doing today will be doing an overview of some of the things I've observed and learned over those years and how we can incorporate materials that we also have at our disposal for really looking into and assessing some of the nuances of mental health issues as they present in the client populations that we may be wanting to build or have access to. So in the course of our conversation today, I'm just going to touch on really the prevalence of how pervasive substance use and mental health co-occurrence happens within at least North America, and what we're represented with as opportunities to build our practice around. I will also do an overview of how the essential identification of addictions are currently done, as well as some of the typical assessments that are used in the field that you will see the majority of programs employing in their process of assessment, as well as a summary or overview of then how those assessments lead to the level of care, specifically the level of saturation of care that someone might require in order to move forward out of their addictive process. And then I'll also do a quick summary and show you some links to the dominant treatment models that are available. And then how do we then build our assessments into probing for concerns that people may have and how we might be able to use them in our own either practices as consultants in large established agencies or health centers, community mental health centers, or even in our own private practices as adjunct services to existing alcohol and drug treatment programs. And then how we might even be able to use some of the types of tools that we have available to track change over time, which is a significant issue and growing issue, particularly with funding entities related to treatment outcomes. So we all know that addiction and mental health has a relatively high level of prevalence within our society. So what I have before you is just really a snapshot. This is from JAMA. The data is a little older, but typically we find that the prevalence data runs about 7 to 10 years behind, and so this is a relatively accurate snapshot of how really much co-occurring mental health issues present themselves with folks who have either primary substance abuse concerns or alcohol use concerns, or combined. And as you can see, what we find is that for example, major depressive disorder for general substance users, this would include the whole spectrum from cannabis to heroin to methamphetamines and so on. As we see the prevalence of about 20% of the population has an established DSM, major depressive disorder, whether it's major depression or dysthymia and so on. Another issue that you often will frequently see is that folks will express having mania or bipolar disorder or some of the symptoms associated with that. And this is actually a fairly high prevalence of that in treatment programs where you see upwards of almost 30%. So, and as we look down through our prevalence information here is that we also will find that there's a high incidence of co-occurring personality disorders as well in the substance-using population. Now, this is an interesting trend that we've seen more of this over the years, and some of that has to do with how the nature of the substance-abusing population has changed over the decades, where there's just a higher level of often criminality that's involved as well, and so you'll see kind of higher prevalence of some of the cluster C personality disorders. So on. So there's real opportunity and reason for us as professionals to be aware of and knowledgeable about how substance abuse treatment is impacted by mental health and vice versa. So what is a substance abuse disorder? from the DSM, this is kind of our go-to point for our start point for really identifying what the thresholds are. And this has changed from the DSM-4 to the DSM-5. And I'll talk about that in just a sec. But for our purposes, it is the concern is about taking substances in larger amounts for longer periods of time than someone means to. Now, there are recreational users that are out in the world, but when it really begins to move into the substance abuse problem phase is that we see that there's this idea of a sense of loss of control where you have more is needed to get the same effects, and you see this is particularly relevant for the opioid types of drugs where you get physical tolerance and then you have an established baseline of normalcy, and then you have to have increasingly higher amounts. There's the concerted effort to try to regulate or monitor use by cutting down, having periods of abstinence, but then not really being able to successfully manage that. Spending a lot of time and energy and focus in getting and using the substances, as well as developing the rituals around the use of the substances, which is a significant component to substance use that many people are often not aware of when they begin to start treating these concerns. And so some of the psychological or sociological aspects of substance use involve some of the ritualized access, the pursuit, the use, the cooking, the preparation, and so on. There's also the presence of craving and urges to use the substance, and very quickly cravings are the kind of more prolonged, focused, I can't get it out of my mind, I want to use, whereas an urge is something that's more of a intrusive, immediate desire to use, but that might actually pass relatively quickly. And often urges can transition into kind of more sustained cravings. Another factor is that they're not managing with themselves well in their life, whether it's in work or home or family, friends. And so you see kind of an incremental degradation of their capacity to function at the level they would be if they hadn't been involved in the substance use. We also find that there's a significant impact on social, occupational, recreational activities because of the use. We might see increased isolation and so on. And that as the substance use increases is that we often will observe that people get themselves into higher and higher risk situations where maybe they're taking risks to obtain the substance that puts them in a serious legal danger or physical danger and so on. And that in spite of all these factors, that there's continued use even when they have known physical or psychological problems that is being made worse by the substance. And that eventually we develop into the phase where we have what we might describe as tolerance, or this is now more understood as a tissue tolerance in many aspects, but tolerance is in effect using you need to have increasingly potent amounts in order to get the same effect. And that when those substances are removed, you're going to have some consistent withdrawal symptoms that are related to the removal of that drug. So how do we typically assess for the presence of mental health problems when we're having addictions? By far, the most common methodology that is used is a clinical interview, and most of the treatment entities that you would be working with or in coordination with. Many of these have developed the guidelines that follow what is considered what we call structured, semi-structured, structured or semi-structured interviews. And the two interview formats that are used the most intensively in the industry are the Addiction Severity Index, which was really designed to walk a paraprofessional through the process of asking the types of questions and use history that would allow them to get enough of the relevant information to give a reliable diagnosis, as well as the CIDI, which was developed by the World Health Organization, which has kind of broader application internationally. Some of these other ones are used more in research programs for identifying risk severity and use severity and these types of things. So the SCID, which was designed around the DSM-5, just walks through all the diagnostic criteria. So it's a very long and somewhat dry test to give, but it's very closely aligned to the DSM. And then a few others that you see less used, but in the public sector, but more used in the research settings. But like I said, by and far, the ASI and the CIDI are used for both adult and also have been adapted for adolescent applications. Okay, so these are great structured interview formats because they allow us to get some reliable information. However, they do have some limitations inherent to them. One is that they may not capture some of the more covert symptoms that are related to substance use behavior and what may be fueling those behaviors. That structured formats are susceptible to impression management and symptom minimization or exaggeration, over or underreporting. And this might have some relevance, particularly when you're dealing with more criminal justice involved clients who have some significant motivation to reduce their the apparent impression of severe substance use. They often will require external corroboration through external resources, and that they typically lack validity measures that are built into them in a manner such as some of the current psychological tests that we have will give. And so that really contributes to the risk for impression management. They also tend to focus primarily on addiction predominantly and the factors that lead to problem substance use behavior, but may not really probe deep enough into other mental health factors or familial factors that are contributing to the onset of the sustained use of substances. And that mental health is often seen as an ancillary component to the primary issue of substance use. And so often evaluators are underprepared to really delve into the underlying mental health concerns, although they may touch on them. Also, because of this, the interplay of addiction and mental health, for example, trauma, complex trauma, so on, is sometimes not fully appreciated by the pure substance abuse evaluator. And that overall within the system, there tends to be an underutilization of structured measures, such as assessment measures that we're going to touch on, to identify both the nature and severity of mental health struggles. And that's often the result of the types of programs that we see, which many of them are public sector, and they don't have adequate funding to really probe into some of these other factors. However, for our purposes as psychologists or clinicians, is that we have opportunities to work with established entities, public entities, as contracts or consultants to build some of these processes in, or as adjunct professionals working in perhaps the private or commercial sector. So who do the structured or semi-structured evaluations for substance use versus other forms of evaluation? Are they better or are they worse? So the best practice in deciding how much care someone needs is really derived from these structured interviews, and it's used to decide how much intervention is needed based on the severity of use. And this is where the ASAM comes in. So ASAM is the American Society of Addiction Medicine, and it is the guidelines which almost all of the treatment agencies within the nation use to reference how much intervention someone might need. So at the highest level, there is what's considered a Dimension 1 of the 6 dimensions, where we are assessing based on acute intoxication withdrawal potential. And for folks who have this concern, we're really looking at medical intervention to stabilize. Okay. Dimension 2 taps into, has questions around biomedical conditions or complications. And these would be things like, are they having, for example, liver damages or cognitive issues that have come about as a result of some of their substance use? Are they having other significant medical factors related to that? Dimension 3 is emotional, behavioral, and cognitive conditions and complications that are contributing to their substance use or are a direct result of their substance use. And this is an area where we might be able to really bring in some of our expertise and hone in and provide some ongoing evaluation and support and treatment related to that. Then Dimension 4 is this idea of readiness to change, and this is built around the stages of change model, which really looks at motivation to go into treatment. That was originally developed around smoking cessation, and then it's been applied very successfully for alcohol and drug treatment and other treatments. And it's built around it's considered a trans-theoretical model where it looks at, instead of just expecting someone to change right away, we look at some of the factors that get them to become motivated to change. Are they contemplating change? Are they deciding to actually implement those necessary changes, but then also planning to do that. And then a lot of the focus of treatment is on the planning phase and then implementation, and then monitoring how those implementations are going and modifying as appropriate, and eventually leaving that change process. So in the old days, folks would show up and they would be told, you have a problem, you got to deal with it, and they would say, thank you very much, I'm not interested, and they would go back out and use and continue with their lifestyle until things just got too bad. So we've been able to be more nuanced in our approach to aligning treatment to motivational readiness. It's an important concept to be aware of. And then the ASAM also looks at kind of the relapse potential. Are they in continued care, which is often where we might be able to work with them and see them in a private setting, and are there continued risk for them to relapse. And then Dimension 6 looks at the recovery environment, family systems issues, and so on that maybe are contributing to their substance use. So the interviews, together with the ASAM placement criteria, really allow treatment entities to be honing in on those risk areas for sustaining their substance use behaviors, and then where to really stop and intervene, help them stop and intervene. So the placement will be on a continuum of care based on the information that is obtained, where the highest level would be medically managed detox services, and then as we kind of go down based on the risk of physical concerns because of their substance use, we will see that they will begin to fall into kind of these categories of residential care, and then ideally, as they have established some sobriety in kind of a more intensive supportive services, they would exit into outpatient services or continued care. And this is often where we as professionals might be able to build our practices in either transition into evaluation processes so that they do get more intensive services, or on their way out where we might be able to provide sustained community-based support for them. Okay. So what I have on the slide, I'm just going to hit on real briefly, is that these are links to some of the NIH, National Institute of Health, best practices in the treatment of addiction. And as you can see, there are a variety of models that have been researched really over the decades. And CBT is a very heavily employed model. 12-step facilitation is, CBT and 12-step are the two primary models that we will see in most programs, which we can then align our services with. Contingency management, if you're not familiar with that, and community reinforcement approaches, these are interesting in that they have received a lot of research and have demonstrated consistently that you can reduce substance use behavior when you really provide reinforcements for engaging in drug-free behaviors by giving them vouchers for purchasing food and so on within the community. The issue with these types of programs, though, is that they require a heavy amount of funding on the front end so that you can get the resources available to give to the clients who do the treatment. So it's ironic, the most successful treatment models tend to be the ones that are the least implemented because of funding limitations. Then the matrix model over the last decade and a half has really been developed to target some of the heavy methamphetamine use issues that we've seen, and some of the behavioral requirements based on where they are in their treatment progress. But if you so your PowerPoint, which you should be getting, oh, actually this isn't opening the link for us. So I'm sorry, I had intended that these would open up links for us, but you can go back later and just Google the NIH, National Institute of Drug Abuse, and all these are links that will give you information regarding the best practice models that might be an easy alignment to your own practice activities or development initiatives in your practices. So within treatment, then, we have a number of kind of focus models. We have opioid treatment. You're probably all familiar with methadone. Buprenorphine is more recently used as an antagonist, opioid antagonist, and allows them to be able to reduce and discontinue direct opioid use, and use these types of medications to become stable as they deal with some of the other psychosocial impacts, and then on their use, and then eventually reduce their use. For alcohol, we also have a number of medications that are used. Naltrexone, you'll see, is used for both opioids and alcohol. And as well as antabuse, you're probably familiar with, which creates a very negative physiological reaction to the presence of alcohol in the system because it interferes with the metabolization of it, and then basically your body sees it as the poison that it is and makes you quite ill. So what are some of the common treatment issues that we see today in alcohol and drug treatment? The first is that addictions has changed over the decades as we've gotten, as our society has developed, gotten more complex, as we have a variety of issues related to veterans, as PTSD. We have issues related to increased levels of criminality within the substance-using population that requires more coordination with established city, county agencies, as well as shifts in the model. And so the model has varied from a highly focused medical model back in the early 20th century to really the implementation of a more abstinence-based model, which got a lot of ground and still is very active today. But there's also has been research on emerging models that are really focusing on how can you can help substance users who may not have to be completely without access to, for example, wine or alcohol or whatnot. And so we've seen a kind of a divergence of models based on the presentations of the people that we're dealing with. We've also seen an understanding of addiction as more of a biopsychosocial problem and not really a moral issue. It's not purely a biological issue, but it's a complex phenomenon that has roots often into early childhood and throughout adulthood. I already mentioned criminality. We also see that there's a greater understanding of mental health problems that are far more frequently identified in substance use behaviors than they were perhaps originally associated back in the early to mid 20th century. And so we have a much more nuanced and complex appreciation for the interplay of all these factors. So the things that we will often see when someone comes in is in treatment with us is and this has also been some of my observations over the decades, is that some of the primary issues that present are that there's a fairly high preponderance of difficulties with emotional regulation, and this would be affect regulation, behavioral regulation as well, and so models have been developed to help deal with that. There's also a more active implementation of kind of cognitive behavioral concepts that look at an individual's cognitive framework, their cognitive distortions, and how we might be able to use cognitive restructuring to help them destigmatize their own attitudes and behaviors that leads them to use of substances. There's a greater appreciation for family systems and generational addiction as it contributes to these behaviors in the people we may be seeing, as well as general affective barriers that are related to, for example, major depression, bipolar disorder, and also some of the frank thought disorders that either may be disposing the individuals to substance abuse, or might be the result of chronic or even acute forms of substance abuse. And so these are all areas of appreciation that we as clinicians can partner with agencies or do ongoing work with clients. So some of the common clinical questions of co-occurring disorders that present themselves are that I've observed over the years and that have been asked to assess in my years is people in treatment may express having some ADD or ADHD problems, and upwards of a quarter to a third of them at times have indicated that they believe that they have ADD and ADHD, and executive functioning issues related to that. There's often the concern that there are cognitive processing problems with memory and encoding and orientation and these kind of factors that are related to substance abuse. That there are other symptoms related to mental health problems that may be present as well, such as OCD or, like I said, mania, or even frank thought disorders. That major affective disorder is a major co-occurring concern in most substance abuse treatment programs now. And it's been thought that many of the development of addictions has often been as a result of really trying to cope with dysregulated emotional problems or bipolar disorder. And once those get stabilize, that many of the impulses and urges to use become less problematic in managing. That obviously there's the concern for thought disorders that might emerge as a result of substance abuse, or that may be co-occurring and complicating substance abuse treatment. And then the presence of personality disorder issues. And predominantly what we find is that these are going to be the personality disorder traits that are going to be associated with the the antisocial, the narcissistic, and the borderline personality dynamics more often than any other of the types of personality factors that you might see. So what does psychological testing bring into the identification of these co-occurring disorders? Well, first is that it provides an opportunity to get really some more nuanced insight into some of the underlying causes and dynamics that are contributing to the treatment struggles and risks that they're encountering. So it's really moving beyond just the pure behavioral problem if you need to stop using, and then things will begin to resolve. Because there's often co-occurring issues related to, for example, PTSD, ADHD, other bipolar problems that may be driving some of those behaviors. Testing also helps us to identify cognitive impairments that may really limit their success in treatment, or maybe making it difficult for them to move forward. It helps us identify mental health issues such as ADD, as I mentioned, bipolar, major mood disorders, and anxiety disorders in particular. Many folks aren't aware of this, but approximately, there's an estimate of approximately 30% of folks who have addiction issues also have a co-occurring social anxiety issues as well that really never gets identified and treated. Testing also allows us to understand the black box and capacity to engage with a therapist, counselors, and peers. And this black box reference really is getting to some of the, when you track the successful pathways through treatment, we've been able to identify fairly reliably what will make treatment successful. But there's this component called the black box, and that is really getting into the quality and capacity for the client to engage with a particular individual in a way that speaks to some of their attachment issues and concerns, and being connected to those individuals. And so there's been some pretty fascinating research out of, I think, Texas Christian University related to this that I would encourage folks to look into. And then there's also, what testing also allows us to do is to assess impression management that may be present regarding minimization of use and these types of things. As well as testing gives us information around negative cognitive sets, kind of rigid thinking, or the secondary personality dynamics that may be impacting treatment that will give us direction for the types of interventions we want to do. And then also testing allows us to track change over time, and I'll give you some samples of that in just a few minutes. So, clinical questions. People would come in and they'd often say, I think I have ADD or ADHD, or I had it in school, and now I started using meth, and the meth was, the cat's meow for me, and I've basically been using it because I think I have ADD or ADHD. And so, how can we begin to assess for these using some of our measures? If you have the clinical question of executive function concerns, and particularly related to adult ADD or ADHD, without the focus on the hypokinetic activity. Okay, and this is important because we will often see this where we have somebody complaining about ADD, but they're not that hyper. Okay, and so we want to be able to tap into more of those typical adult manifestations of this. And so, the Brown scale was really designed for this exactly. And Dr. Brown is retired. I think he was at Yale, and had built his work around looking at the executive functioning components of ADD, and also looking at contextual variables that contributed to the manifestation of that, unlike other types of ADD measures. So what I have is a sample. So using the Brown, it's a rapid assessment tool. You can give it digitally, you can give it by hand. But when you get your information back and you score it, you will see that it provides a very direct representation of some of the clinical concerns that might be presenting themselves. So for example, this is a profile of someone who's presenting as that they tend to have more impulsivity in their actions. So they would be less inclined to resist engaging in enticing behaviors, for example, and that they're also expressing some memory impact because of their executive functioning problems. So this really relates to their ability to focus, stay on target, on task, and use some of those executive functioning capacities to store information and to retrieve information from their memory structures and systems. So this is relevant for treatment because a lot of what we do in alcohol and drug treatment has a lot of kind of language and narrative components to it, having people tell stories and remember things, and also giving them information that we're asking them to focus on and remember. So having some idea of executive functioning impairments can be a good supplement to treatment and could be treated with medication or other behavioral interventions. The Brown also gives you it breaks down the item responses by kind of level of severity. So, for example, is there no problem or is it a big problem? And so on a Likert scale. So you can really get an idea of how they're reflecting their concerns around executive functioning issues related to attention deficit problems. The nice thing about the Brown also is because it's so brief, it's what I would call a rapid assessment instrument, and I'm a real believer in using rapid assessment instruments to both do initial baseline testing to kind of see what's going on, but then to use it again for follow-up sessions from time to time to see if there's been any positive treatment response either to medication or other behavioral manifestations you might be focusing on with them. Okay. So if the clinical question might be more kind of basic cognitive processing concerns, which often would come up, what do you use for that? So doing a full neuropsych evaluation for somebody who has substance abuse concerns isn't always very practical. Actually, it seldom is, and so it actually doesn't usually happen unless there's been some significant TBI or infarct related to their substance use behavior. But what can we do as ground level practitioners is we can use a rapid assessment instrument such as the RBANS, which is the repeatable battery of neurological symptoms, and it was really designed to be administered by paraprofessionals but then interpreted by qualified professionals. And so you can work collaboratively with external treatment entities to track change and over time as people begin to clear, for example, as a result of their treatment. So what the RBAN taps into is you get a total RBAN score that's really based on these 5 domains of delayed memory, attention, language, visual, spatial, constructional abilities, and immediate memory. So it's a nice snapshot of these areas. And so here's a sample of what somebody who may present with some neurocognitive processing problems within a treatment program might have. So for example, if 10 would be the standard score, that would be where we would like to see people or higher. So here we have a sample of a profile where someone is significantly having struggles with kind of visual figure copies. So there's some visual motor integration problems. There's also some recall problems around story memory and recall, which is more of a contextual memory probe. There's also some list learning, which is just basically give them a list of words and then ask them to recall those words in sequence, and some other kind of recall tasks and so on. So coding is a visual spatial processing task. So when you see someone in treatment who's presenting with this and you're doing a heavily focused language-based treatment, you're going to be probably dealing with some cognitive learning problems with memory encoding and retrieval that you're going to want to make some adjustments for, and perhaps even be inclined to engage in more experiential treatment early on, or concrete behavioral treatment early on. So the RBAN also gives you a nice synopsis of those domains over here of the kind of the general clinical scales, clinical domains, so as a snapshot. So this is a very handy tool in using in collaboration with treatment programs. So if the clinical question is psychoticism or mania is an issue, or there are other dominant mental health issues, the MMPI-RF is a good tool to really probe into some of those underlying more psychopathology-based issues that are perhaps more severe, as well as building in validity measures, which gives you some really good indications of impression management concerns and reliability of their reporting. Another good tool is the Symptom Checklist 90, which is a broad it's a broad tool for assessing the prevalence of dominant mental health concerns, and is aligned to the DSM. And this is, the SEL-90 in particular it's more face valid in the MAPI, but it's a good tool to use because it's also pretty brief to give. So what I've included is a sample of an MAPI profile for an individual who had been arrested for engaging in some aggressive behavior, and was believed to be, he was observed to be exhibiting some psychotic symptoms, ideas of reference, kind of highly spiritual content in those ideas of reference. 28-year-old male, he was taken to a psych unit for observation and a hold, and it was believed that he had possibly been under the intoxicants of cocaine or some other drug. This is an individual who had prior treatment evaluations, and really they were looking at what was going on with this individual. Does he have pre-existing psychiatric concerns or being exacerbated by substance abuse and so on? Curiously enough, this individual had no prior involvement in the mental health system, but he had been significant efforts at trying to get sober through substance abuse treatment programs, but was not successful in doing so. Immediate life stressors is that he went through a recent breakup, he had a fight and got arrested, which led to this whole incident, and that he had really hurt somebody as a result of his aggressive behavior. And as I noted, he was having some spiritual preoccupations, religious preoccupations, and it was determined that he had basically been on a crack cocaine binge, and this was a part of the profile that they were trying to kind of figure out what was going on with this individual. So he was given the MAPI, RF, upon admission, and I'm not going to do an exhaustive review of the RF, as we have a number of very good webinars that are available for you to really do some drill down into this to understand it more fully. But for our purposes, the MAPI does give a nice snapshot of where this individual is falling and relative to a comparison group. So in this particular profile I have up, is we're looking at a psychiatric inpatient community hospital, okay? And these are the validity scales that are available on MMPRF. And what you see is that his profile, for the most part, falls within the range of folks that you would see within a community mental health psychiatric inpatient unit. There are a few anomalies. One is that we have the FBS scale, which is the symptom validity scale, is that he has some kind of extreme exaggeration of symptoms outside of the typical norm for an inpatient psychiatric group, but otherwise he is within the range almost across the board for validity indicators. And we typically would see that people who are having an acute psychiatric crisis will have elevated infrequency scales. For example, the S scale right here, which you can see this, I can highlight that for you, which is right in the the mid-range for what you would anticipate. So right away we get some indication that this is probably a valid profile. We can determine it's a valid profile of this individual. And then when we begin to look at some of the various scales that the MAPI offers, is that we have what we describe as higher order scales. So we see that he has two significant elevations, but still within the range for psychiatric populations. On the externalizing, internalizing dysfunctional scale, as well as right here, as well as the behavioral dysfunctional scale. So we are really seeing some consistent activation and aggravation of both internal and external distress, behavioral and emotional distress. Then as we look at the RC scales, or the restructured clinical scales, we see that we're having some considerable concerns around demoralization and distress. This is also maybe considered, you can consider this as like psychic distress. This is emotional psychic pain. So this individual is telling us that he is not in a good place, and he's having both internal and behavioral struggles related to this, as well as some very high scores on the RC4, which would be consistent with his acting out and aggressive behavior and so on. So what we're seeing is that we have a psychiatric profile that is consistent with someone who has considerable concerns around his immediate thought disorders and behavioral dysregulation. And it may likely be exacerbated by his cocaine binging behavior. And then when we look at some of the more specific domains, we find that we have some hits for us on the somatic concern domains, regarding some gastrointestinal problems, as well as some cognitive issues around expressed difficulty in concentration and thinking and whatnot. And then as we look at the internalizing scale, we find that there is a very there's a very high score on the suicide risk. Okay, so this is something that would be important for us to know, particularly as he is coming off of his cocaine high and will probably have a significant crash. So observation of this individual is going to be real critical, clearly. And then we have some elevation on anger proneness in the internalizing scale, and some other activation related to his psychiatric crisis. And then as we look at the externalizing scales, we see that there is a significant history of substance abuse, which is no surprise since he's being arrested for cocaine-induced or cocaine-exaggerated psychosis and aggressive behavior, as well as attention problems and acting out problems related to his impulsivity and difficulty regulating himself. So the nice thing about the MMPI is that it also gives you kind of an overall what we call the Sci-Fi scales, and these are stable personality factors related to this individual or how individuals present. And what he is sharing with us based on his responses is that he has a fairly high level of kind of negative emotionality. So he is often in a relatively suffering place. And this is consistent with also his identification of suicidality and these types of things. So let me skip over the slide. The MMPI also will give you some of those critical items that allows you to kind of follow up with later, such as suicidality, acuteness of suicide risk, and these types of things based on his self-report, or other critical issues around thought disorders or anxiety and these or depression and these factors. So it's used quite a bit actually in some of the private sector treatment programs, and can also be used in an outpatient basis as well to inform what you're probably going to be having to deal with. So the Symptom Checklist 90 revised this is a nice snapshot of the prevalence of kind of immediate presentation of clinical symptoms. And as you can see, it covers somatization, obsessive compulsive, interpersonal sensitivity, depression, and so on. And so this profile is just a sample of someone who's presenting with kind of right here, kind of a fair amount of clinical distress across a number of scales, particularly around interpersonal sensitivity, hostility. So this is someone who is very sensitive and reacts poorly to that sensitivity, and as well as having some paranoid ideation and potential for psychoticism. So highly sensitive individual. It's a quick snapshot of some of the presenting factors that you may want to address or refer for medication treatment and so on. Okay. So if the clinical question is a specific mood or anxiety concerns, this is where the use of rapid assessment instruments I think become very helpful, particularly if you've ruled out that there's not kind of frank psychoticism or other extremely dysregulated emotional or behavioral problems. So for this, I would suggest that you consider pulling in the Beck inventory tools, which really look at depression, hopelessness, suicide risk, and anxiety. So this is a sample of a BDI, the BDI-2, and as you can see, based on this face valid report, this person's indicating a high level of depression, okay, or a negative mood. Okay, so this is something that you can use to begin targeting specific interventions related to mood regulation and reduction of negative mood. The nice thing about the Beck is that it also assesses for some of the subcomponents of the items assessed for pessimism, and why that is important is that pessimism is directly related to hopelessness. And so if you get a positive hit for pessimism and endorsed items like I don't have much hope for my future and these types of things, then I would definitely be following up with the hopelessness scale. And the reason is if someone is depressed and they're hopeless, we want to know how hopeless they are. And in Beck's research in the development of the BDI is they were able to predict within a 15-year period that 3/4 of the folks who had high scores on hopelessness had either attempted or successfully completed suicide, which is a very high ratio. So using the Beck hopelessness scale, when you have a suspicion of pessimism as assessed by the BDI is a really important thing to follow up with. And if this individual consistently reports now a high score on hopelessness, well, you are looking at a potential risk for suicidality. And I would then suggest that you consider following up. These are, by the way, the items, so you can look at the item-specific responses. But that you then follow up with what is their risk for suicide. And the Beck Suicide Scale gives you information on active versus passive suicide ideation. And as you can see, this individual, while they had a high score on depression and feeling hopeless, they are not reporting that they're at really significant risk for suicide. And so our focus can be less on kind of stabilization of immediate suicide risk and more how do we improve their quality of life and then ultimately reduce the level of depression and do some of the CBT that may be helpful for that or other models of treatment. Okay. So psychopathology, a psychopathological personality is the primary concern. You might start with a test such as the SEL90 or the MMPI, but those are really designed for kind of the front-end assessment. There are other tools such as the NCMI that is designed for identifying the degree of concern when there's known problems in place. And so the MCMI gives a nice probe into what personality variables may be at play that are contributing to your treatment of these individuals. And so as you can see, we may have somebody who is scoring high on histrionic traits, maybe scoring high on narcissistic traits, and high on borderline traits. Okay, and this is actually fairly frequent in alcohol and drug treatment, where you'll see a lot of folks who do present with some of the exaggerated externalization or internalization of negative identity factors and whatnot. And so, many treatment models have started to incorporate intervention to really begin to target some of these, such as incorporating DBT and these types of treatment models. So the MCMI is nice in that it really gives you kind of an understanding of what's the playing field you're dealing with somebody in outpatient treatment. So as a private practitioner, where are the opportunities to provide clinical care for some of these co-occurring mental health problems? Some of this I've already alluded to. As contractors or consultants, we can work with treatment programs to provide these evaluations, and I think there's dominant opportunities in the private sector aspects of the treatment world. However, many states have actually started to open up testing for Medicaid-funded clients, and so this was with really the advent and rollout of Obamacare. Historically, evaluations were not paid for by Medicaid dollars, but in the last 5 to 6 years, we've seen that begin to open up, and so there are opportunities for psychologists and evaluators to do these tools and actually be compensated now in public sector agencies for evaluations. And so, if you're not working for one full time and you're doing this, you can build links and liaisons with some of these programs to do this. Also, as a private practitioner, I think there's great opportunities for us to work both on the front end for identifying folks who may need referral to treatment and providing mental health support while they're going to either inpatient or intensive outpatient or aftercare programs, as well as on that back end when they're coming out of those programs and you're continuing to work with them and sustain their stabilization and growth. There's also great opportunity to do group therapy as a practitioner with folks. And in my own work over the years, is I would do actually quite a bit of this group therapy, doing DBT, which would be applied for folks who obviously have some of the traits related to emotional dysregulation, disinhibition and dysregulation. But it also is very useful with folks who had complex trauma or generational trauma, because many of the skills would be applicable to those groups. But knowing what they're coming in with was also very helpful, because I would be able to hone in and deal with some of the fragility of their personality structures if I was aware of them and didn't have to wait for them to manifest themselves. CBT is actively integrated in most treatment programs at some level, whether it's for mental health and disorders that are related to depression or anxiety predominantly. And at times there are some opportunities to do stabilization groups for folks who have more overt or frank thought disorders or other severe mental health disorders. And I also already mentioned DBT, but you're going to find that DBT is a very nice complement to, for most forms of alcohol and drug treatment, because it provides a scaffolding that the clients can use in rebuilding how they're approaching their emotional regulation world, as well as for the therapists to fall back on when they're dealing with challenging behaviors. And when I say DBT, by the way, I'm also really talking about DBT-informed treatment models. There are the Linehan best practice models, which are geared towards just dealing with the borderline personality disorder spectrum of behaviors. But many agencies have incorporated DBT in alcohol and drug treatment as well, as many of the tools are very helpful for folks in regulating their behavior that they struggle with now that they've removed the substances from doing that for them. So what do we focus on in active treatment? Emotional regulation skills, training to help manage that disinhibition and dysregulation of particularly negative affect by teaching mindfulness, acceptance versus change. And often what people will have to do is learn specific skills to implement change. Sometimes it doesn't work, and they have to learn to find a place of acceptance and letting go of things and moving on. And these are all very nice adaptations that you can use to supplement care, and often keep people from blowing out of treatment, quite frankly, because it gets pretty raw when people are in alcohol and drug recovery. And learning mindfulness and acceptance and change skills can keep them from blowing out and having a treatment failure experience in many instances. The other thing that I think we have opportunities to work on an outpatient basis or in practice in alignment with other as aftercare, for example, is once folks have been stabilized and they begin to really need to drill down into some of the underlying attitudes and factors that contributed to their choices and their high-risk behaviors, is doing cognitive restructuring for anxiety and depression and other and bipolar disorder, for example, and identifying when their thoughts of use begin to emerge and they ruminate on them and they have an urge that develops into a craving, and really how can you help them identify their AT, which is automatic thoughts that kind of lead them down the pathway towards eventual relapse or full-blown use. And helping them identify the distortions in their thinking and become evaluators of their own thought processes so that they don't just take a piece of data and believe it hook, line, and sinker. But most importantly is that you help folks really develop a rational response to their distortion process and then implement these rational responses in real-life application and work with them to look for ways of doing that, and then help them evaluate the success or failure of the application of their rational responses, and then reframe, recalibrate what they're going to do, send them back out, have them do it again, and then eventually find ways of building success and end efficacy in implementing new behaviors. Okay, so somebody who is having significant cognitive problems, for example, or who's having memory and focusing problems, they're going to have a little bit more of a struggle in doing some of the CBT types of skills, which I have observed in the past. All right, so other clinical focus areas for adjunct treatment include family systems, family of origin. ACEs, if you're not familiar with that, is the Adverse childhood events. This is basically the more exposure we get to things like domestic violence in the home, broken families, addiction, mental health problems in the home, is that it increases our risk for developing actually medical problems and behavioral health problems later in our life. This was developed through early adverse family stresses. This was developed through the Kaiser Foundation and NIH, looking at longitudinal data at early morbidity, and this kind of grew out of that. But other focus areas that are really relevant in alcohol and drug treatment are attachment issues that have come up. And so I think that some of the psych testing, particularly related to the MCMI, gives us some indications that there may be some significant attachment injuries that may be driving some of the personality styles or disorders, which is often consistent with what we see, is that attachment injuries are a major component of many of that. The other areas are around neurological memory functioning and attachment. This is particularly relevant to some of the work that was done on identifying how early memories and instability in life can lead to kind of problematic attachment experiences and how these can manifest later in life. We might consider these developmental traumas, as it were. And then generational trauma. This is particularly relevant in minority communities, I found, or communities of poverty. I worked with the Native American community for many years, and generational trauma was a major focus. And so, assessing for how those have been those issues have been impacted on their daily life is something that you can also kind of focus on and track over time. And some of the tools around depression and anxiety and so on. Codependency and boundaries. This is an area that's a very active focus in alcohol and drug treatment, and it's something that we can use as well. The concern about codependency in the lay community, in the lay treatment community, versus kind of what we know about gender norms, is that these tend to follow gender lines, and so codependency may be something that has more of a gender bias to it than we've really been able to delve into very much. It's an interesting area of research. So, and then family of origin issues and projections into their current life, and so these are often areas of focus. So thought disorders, we often will need a multidisciplinary team to provide medication and other wraparound services, and you have to work collaboratively with them often to do this. But what's important for us is that we can track change over time through some of the rapid assessment instruments that I mentioned, such as the SDL-90. Personality disorders is that we would use CBT or DBT type programs to focus on the reduction of how these mood issues are manifesting from the predominantly, or behavioral issues are manifesting that are being driven by the personality disorder issues. And we formally call those axis 2, not axis 1. But then we would want to really weave in skills to apply these skills into managing some of the maladaptive manifestations of personality-driven problems. And we can track that again through some of the rapid assessment instruments I've referenced. Cognitive impairment issues, we can assess and track these with the R-bands, and the R-bands was designed to track recovery from a variety of concerns, whether it's post-stroke or post-TBI or post-acute withdrawal from substances, which is something that, if you're not familiar with, it's a phenomenon that happens when people have been in recovery for a little bit of time, and then they start to have some anomalous cognitive issues and emotional issues that emerge seemingly out of the blue, but it's understood as post-acute withdrawal. We can also track response to ADD or ADHD interventions and provide behavioral management tools for them. And we can use the Brown to track response to treatment and how they may be resolving some of those issues and concerns. So we're out of time. That